Good afternoon, everyone. My name is Dr. P.J. Maddox. I'm chair of the Department of Health Administration and Policy at George Mason University. It is my pleasure to welcome you to the first of 5 health issue policy panel sessions featured by the Center for Health Policy Research and Ethics this year. And it is also my pleasure to introduce the new director of the Center for Health Policy Research and Ethics at George Mason University, Dr. Alison Cuellar. Dr. Cuellar will be serving as the moderator for today's panel. Alison is an accomplished health services researcher with background and interest in policy and policy analysis on a number of fronts that align well with today's featured panel. She's also an accomplished academic, having degrees from the University of Texas and a PhD from the University of California, Berkeley, in health services and policy analysis in economics. So without delay, I'd like to welcome you all again and hand the panel over to Dr. Cuellar.
Good afternoon, everyone. Thank you for joining us. It's my pleasure to introduce this phenomenal panel we have today. I first want to welcome Amira Roess. She is a professor of global and community health here at George Mason University. She's an expert in infectious disease epidemiology, a coronavirus expert, and previously an epidemic intelligence service officer at the Centers for Disease Control. Welcome, Amira.
Thank you, Alison.
Ed Maibach is a distinguished university professor at George Mason University and the director of our Center for Climate Change Communication. He's an expert in public health communication and social marketing, and he recently conducted an exciting study of public attitudes and behaviors, and we are eager to learn about those results. Welcome to you, Ed.
Thank you, Alison.
And Ashley Thompson is Senior Vice President of Public Policy Analysis and Development at the American Hospital Association. And previously, Ashley, I understand you were a health policy advisor on the U.S. Senate Finance Committee, working for Senator Grassley. Your hospital members, of course, are on the front lines here, and I'm sure there's a great need to share lessons between your membership and the policymakers. Before we entered the session, it sounded like it was daily, if not hourly. We welcome you as well.
Thank you so much.
To start us off, our audience has been tracking the news and major developments from public health. We have heard about the importance of sheltering in place, social distancing, washing hands, wearing masks, flattening the curve of the epidemic. From delivery systems, we heard about challenges, personal protective equipment, ventilators, COVID-19 testing capacity. More recently, it seems like we're hearing indications of improvements in these areas. We've also reached a few difficult milestones. In the same week, we passed 100,000 deaths nationally. Many states started reopening, including here where we are in Northern Virginia. Amira, can you start us off and help us understand this picture? What is this miss as we're trying to understand where are we now with COVID-19? What metrics are you tracking and what places or activities are you paying close attention to?
Right, thank you, Alison. So we are really paying close attention to the hospitalizations and the number of deaths that are occurring moving forward. It's important to note that lots of places in the U.S. have been able to what we call flatten the curve, and that means that they've kept the transmission rates at a steady number so that the hospitals wouldn't get overwhelmed. Now, once jurisdictions reach those milestones, which is essentially 14 days of very little growth in number of hospitalizations, cases, and deaths, then the jurisdiction is allowed to enter phase 1 of reopening the economy. Now, during the phase 1 and phase 2 and phase 3, we're encouraging and in some cases requiring that really non-essential movement doesn't happen, and that most individuals, if they can stay home, should in fact stay home. Phase 1 especially is sometimes referred to as a stay-at-home light. And I think this is a really critical message that many individuals are missing. They are thinking that phase 1 means, I can go back to work, shopping, social activities, And they're forgetting that really we still need to wear the masks when we're out in public. We still really have to maintain the social distance of at least 6 feet apart. And when you can, stay at home. So as jurisdictions have entered phase 1, they're really keeping a close eye on those key metrics, the hospitalizations, the number of cases, the number of deaths, and also the amount of PPE that we have, the amount of testing kits that we have, and in some cases, the number of public health personnel and contact tracers that are available to work on what we expect to be some small outbreaks as we move through phase 1 and into 2 and so forth. In the last week, we've also seen a real surge in number of protests, and this is of particular concern because we are worried about outbreaks happening because of the protests. And so that's another thing that we're keeping an eye out on. And there's been quite a few leaders who are encouraging individuals that have participated in protests to consider getting tested. In DC, for example, the mayor there has really urged individuals to go ahead and get tested. And the health commissioner is keeping an eye on and maybe an increase in cases in the next couple of weeks.
Thank you, Amira. Ed, turning to you, you and your colleagues at Yale conducted a survey on Americans' attitudes and behaviors around this pandemic. First, I want to commend you on how rapidly you were able to conduct this work and summarize the results and release them. Tell us, please, how you conducted the study and what lessons you draw from it.
Yeah, I'd be happy to, and allow me to acknowledge the role Amira played in our survey as well, which is really incredibly important. It was an important opportunity for us to have an expert on coronavirus like Amira at George Mason, who was willing to drop what she was doing and help us make sure we were asking the right questions that were actually informed by the science, because that's really the reason why we do these surveys, to make sure that people understand what is important for them to understand so they can make better decisions about protecting themselves, their family members, and other members of the community. So what did we learn? We conducted the survey in early April. We learned that, I guess most importantly, we learned the obvious, which is that most Americans were incredibly worried about COVID infection at the time. I'm fairly confident that is still the case, although I'm going to mention in a moment, I suspect it's somewhat declining. But so people were worried. We also learned that people were taking a whole range of different important, relevant, self-protective actions. Actually, I shouldn't call them self-protective actions. I should call them protective actions. Actions that will, in fact, help protect them, but really the defining motivation for people engaging in these actions is to protect others. So we learned that as well, that people really understood, Americans understood that these actions are things we do because they protect our loved ones and members of our community. And that was good news, the fact that that message was coming through loudly and clearly. We happened to be in the field conducting this survey over a 5-day span. On the it was like early in the week, like let's just say Thursday or Friday, we went to the field. We came out of the field on a Tuesday. Saturday night, CDC held a press conference and they recommended that all Americans start wearing masks. You can't, when you are in the survey research business, you cannot possibly get any more lucky than to actually be in the field conducting a survey when a natural experiment has just happened. So literally, we had the ability to look at the degree to which, or the rate at which people were wearing masks before CDC's recommendations came out, and then after. And we actually now have a paper. It's just like the fastest I've ever published a paper in my whole life. We now have a paper published in Frontiers of Public Health and Frontiers of Communication. It just came out earlier this week, which showed that there was an immediate bump up by about 12 percentage points of people wearing masks from before to after CDC's recommendation. So this is another piece of good news, something that we learned that is incredibly heartening. Not only were people appropriately worried, not only were people taking actions, but when our Centers for Disease Control recommended that we all start wearing masks, we got an immediate significant bump up on that particular behavior. And we compared the bump up in that behavior to all of the other behaviors that we were asking about, which was, I don't remember the exact number, well over a dozen. And so the other behaviors didn't change, that behavior, an immediate bump up by 12 points. So again, another piece of good news. And then lastly, we learned in another paper that we submitted to the New England Journal, and they rejected it, no surprise. We looked at the effect of social norms on people's protective behaviors. So we asked our survey participants, essentially, to what degree do your friends and family members expect you to take actions, appropriate protective actions to prevent against COVID infection? And what we found is a very powerful relationship between people's perception of a social norm, that taking protective actions is the right thing to do, and the entire list of protective behaviors, which, again, I'm blanking the number. I don't remember the exact number we asked, but I do remember in my notes that 11 of them were, 11 of the relationships between social norms and protective behaviors were stronger than an odds ratio of 2.0, meaning perceiving a social norm to engage in protective behaviors doubles or more than doubles the rate at which people were engaging in 11 distinct protective actions. The important implication of that is, and it's perhaps less relevant today than it was in early April, but certainly in early April, the important implication was if you have loved ones, family members, neighbors who are not engaging in protective actions, you should explain to them that it's in their best interest and our best interest for them to do so. And when you do explain that to them, they become much more likely to engage in appropriate protective actions.
Excellent, thank you. If you don't mind, Ed, we have gotten a question. Could you tell us a little bit about the methodology? I presume this was a telephone survey. Can you tell us a little bit about how many people participated and where in the country you fielded this?
Sure. It was more or less a nationally representative survey. I'll qualify what I mean by that. The survey was conducted via the web. So all of our climate change in the American mind surveys are also conducted via the web. That's my day job, by the way. I conduct climate change public awareness surveys, not COVID public awareness surveys. But it was not, the method we used is not the most rigorous method, simply because the most rigorous method available to conduct representative surveys of Americans on the web costs about $75,000 for 1,000 participants. We wanted more than 1,000. We actually ended up surveying 4,000 participants. We used a less rigorous method. It is still nationally representative. We did post, we weighted the data after we received it to make sure that it was representative of America according to key demographics that we track.
Marvelous, thank you. And Ashley, turning to you, please. Much of our news comes from health systems in New York City, where the pandemic has hit particularly hard. How is this picture unique compared to hospitals in other parts of the country? And what is the most important thing, in your view, for our audience to understand today?
Thanks, Alison, and thanks for having me. And you are right, our hospitals are in very different places, but for all of them, we think that this is one of the biggest financial challenges that hospitals and health systems have faced in decades, if not the history of basically America and when hospitals were created. The hospitals in New York have been faced with an onslaught of COVID cases, and the extreme cost of them have put them financially at risk. I think you've seen some of the news reports of those hospitals losing billions of dollars in caring for these patients. They had to struggle with revamping their entire operations to prepare for this influx of patients. Many of them had to convert other units so that they could be ICU units. We've seen that with this disease that a number of people need intensive care, and many of them are placed on ventilators. And the use of those ventilators extended much longer than the average use for patients that are put on vents, especially if you just have regular pneumonia, where they've been on it for 2 to 3 weeks, which is what created backlogs in the ICUs. I think we also struggled with workforce issues in New York, but we were able to make changes with the administration to allow physicians and other practitioners to cross state lines. I think that in New York in particular, they had to be creative about construction and creating new pop-up tents to screen and to test individuals. There's concern about adequate amounts of PPE or personal protective equipment for the care teams and clinicians. I think there were a lot of unknowns with the disease and how it was transferred, which actually caused, people in maternity units. You're going there for, a normal newborn delivery, not knowing that you had COVID or that you could spread it to the doctors or nurses that were caring for you there. So we've had to make significant changes, especially with social distancing. So that's one aspect of it, and some of the just extreme challenges of getting patients the care that they need. And I think that we were really concerned that America might go by way of Italy, where hospitals had to make life-saving decisions or just rationing care. And given just the huge influx of goodwill that was given to hospitals and some really creative ways to share equipment like ventilators, I don't think that there was a case where patients needed ventilators or other equipment that wasn't available to them. And I have to say, I give great hats off to the administration. We really did work with CDC and FDA and HHS and CMS, the alphabet soup, DEA, in order to loosen restrictions, because it's not just the ventilators. There's medicines that you need to do to relax patients in order to intubate them. And actually, when you intubate them, they've learned that that's when the greatest they're not spores. I mean, Amira would know much better about the ways, but that's the greatest concentration of coronavirus is released. So in any case, that is one aspect of how hospitals are dealing with the situation. But just as importantly, all the hospitals across the nation emptied their beds and stopped elective procedures, non-urgent services in order to prepare for this wave and this influx like we saw in New York. And in doing so, most of this was orders at the national level where they said, we highly recommend you cancel elective surgeries, all the way to the local level where a number of governors said you may not do this, and then they issued stay-at-home orders so patients weren't able to come into the hospital. But without those revenue streams, hospitals are losing just as much money because they don't have patients that are paying them to receive services. So we've seen across the country, especially in rural communities, hospitals really struggling to survive. I know that you've seen a number of furloughs that hospitals have needed to do, which is counterintuitive because you're thinking that they're going to have this big influx of patients. AHA did its own study, which found that these two factors, the canceling of elective and non-urgent surgeries, procedures, and services, combined with the increased cost of treating COVID-19 cases, resulted in a loss to hospitals over this 4-month period, March through July, of $202 billion. It was basically $50 billion a month. Hospitals and health systems across the country were losing financially due to COVID-19, which has just created huge stress. And before I turn it back over, I just want to also say that I acknowledge the events of the past week. And we really almost have two pandemics. We have the virus, and then we also have the violence, and then you tack on that the economy and how that disproportionately impacts certain patient populations, that this has just been a huge struggle for both our workforce as well as our hospitals and their communities.
Excellent, thank you. Amira, I wonder if you could tell us a little bit about contact tracing. So as I understand it, the contact tracing should aid health departments, help them to get care to residents that need it, stop outbreaks, anticipate and prevent further transmission. If we imagine you include mapping capabilities, that helps us visualize the clusters of outbreaks, how many people are affected, where are the high-risk locations, maybe how many new hospitals might be affected. How well do you see these systems working? Are there some standouts that you can think of? And what lessons are we learning for a possible next time?
Right. So contact tracing is a really important part of outbreak response and in really controlling the spread of this virus and of any infectious disease, really. Contact tracing goes hand in hand with testing and with getting messages out regarding quarantine. One of the biggest issues that we've had early on is that the health departments were overwhelmed and they weren't able to deploy contact tracers quickly. On a good day, health departments are often stretched. They have too many things that they're working on, and we've known for a while that one large outbreak could put many health systems in this country over the edge. And unfortunately, when we're talking about large outbreaks, of course, a pandemic is going to make it a lot worse. And so the way contact tracing typically works is you start off with a report of an individual who tested positive, and that's reported to the health department, maybe through a healthcare provider or some other method. And then the health department will deploy one or more contact tracers to interview the individual who was infected to find out where they may have been, who they may have come into contact with when they were infectious. And after that activity, the contact tracers are really meant to quickly identify and interview those individuals who have come into contact with the infected individual. And what you want to do, especially in the case of COVID, is make sure that those contacts are self-quarantining and they're monitoring their symptoms very carefully. And ideally, you would also test them during a time period when you think they may have evidence of infection. And of course, that is very difficult to do during a pandemic when you don't have enough contact tracers. And as we all know, we didn't have enough test kits. And we also had some problems with the quality of the test kits that were on the market. And so it's been nearly 4 months of learning lessons from this and trying to prepare the health departments and universities and employers and others for reopening the economy. And what we're seeing now is many health departments throughout the country are really trying to ramp up their contact tracing workforce. In Virginia, for example, our goal is about 1,300 contact tracers. And we are at about 350 contact tracers that have been trained and in the system. And so, we're seeing health departments quickly try to ramp this up. And we have Medical Reserve Corps and other groups that are also training contact tracers and trying to contribute to the effort. So contact tracing is a really important key, and it goes hand in hand with having good tests available and a system in place that allows us to relay information quickly between all of the stakeholders that are involved in outbreak response and in really trying to control transmission.
Thank you. I wonder if we can tie this, Ashley, to the agenda for the health systems. Is public health preparedness, once we come out of this, perhaps, and we can think more clearly about preparing for the next time, sort of what pieces of this are on the health systems agenda in order to support the health systems in the work that they do? So they're on the acute end. I imagine they're vested also in the activities of the public health department and in a robust public health system. So what sort of collaborations do you see that may or may not be different than they have been in the past with respect to developing policy options going forward?
You know, what you might not realize is that hospitals and their public health departments often don't interact. Every situation is different, though there are actually some hospitals that actually act as the public health department of that community as well. So there are varied circumstances across the country. We actually see that many of the inner city urban hospitals are the ones that are safety net hospitals that do a lot more of the public health initiatives for that community. And we have some public health, some hospitals that concentrate a lot on the social determinants of health, but they do that just based on their own mission of wanting to do things like food pharmacies or ensure free transportation or limit violence in their communities or a number of aspects of what we will consider alternative factors that are critical to ensuring the health of the community and of individuals. I think that from this pandemic, we've learned that our public health infrastructure is underfunded and not well coordinated. I think that from a hospital and health systems perspective, I'm not sure all of us want to be the public health system. I know that testing might be something that is pushed upon us, and some might be able to handle this better than others. I believe that when we look at it, we are really looking at the short term of what actual flexibilities that the government gave us and put in place now that we want to continue, I would say, through the pandemic, but it might be more than that. It might be until a vaccine, or it might be until a large portion of the population is vaccinated. And then there's what do we do after that? And so there's kind of this delineation. What do we do during that maybe 18-month time period? And then what do we make permanent? And so I'll give you an example, something like telehealth. That's not public health, but the telehealth capacities that have been achieved over these last 3 months, you know, might have taken 3 to 5 to 10 years. So we're looking at maintaining some of those innovations that have occurred during this pandemic.
Thank you. Turning to you, Ed, your study speaks to the need for targeted communication strategies. Are there federal or state policies that could promote this, or do you see this mostly as a sort of individualized local effort?
Okay, you're asking a tough question in the sense that it's my sense that our federal response to this has been a mess. And we've got all kinds of really deleterious messaging coming out of the federal government. Fortunately, we actually asked this question in our survey. We asked people who they trust, whose information are they paying attention to? And people have a lot of trust in, of course, in their own health professionals, their own doctors. They also have a lot of trust in their own local public health officials. So that's a really good thing because I think it has served America quite well in this pandemic. What I want to go beyond what I actually know from our survey to what I've just sort of observed as a result of being alive here in the U.S. during this pandemic, and that is, you know, the results I shared with you thus far, which I found to be quite cheering, which were collected in a survey in early April. Well, now we're in early June, so we've seen, I think, I don't have data to prove this, but I think we have seen public opinion about COVID evolve pretty rapidly and pretty dramatically, such that the same kind of political identity politics that is so poisoned the issue of climate change, which is what I normally work on, really seems to also be at work poisoning public understanding of the COVID epidemic, or at least public support for protective actions and public support for protective policies. So it's incredibly detrimental to the public's health and well-being when we forget how important it is to trust the experts, because the experts are not, public health experts are not in this for personal gain. They're in this for to protect and to promote the public's health and well-being. So it's really a grave concern to me that I think we are seeing an erosion of trust among some Americans in terms of what public health professionals are advising them to do. We certainly see that in different states, different states are opening up at different rates, and which is, if that's based on the numbers, fine, that's great, as it should be. If it is based on partisan thinking, much less encouraging.
So Ashley, you're probably not surprised to see this either. Once again, according to Ed surveys, the Americans have expressed a strong level of trust in their medical doctors. What role do you see for providers in communicating to the American public around the pandemic? Do you see them as a formal role, playing a formal role, or is that one they would tend to not want to play, specifically around how the disease is transmitted, how to prevent it, how to treat it?
That's so interesting, and maybe the AMA, the American Medical Association, through its doctors, or the ANA, the American Nurses Association, would have different viewpoints. I don't know of our hospitals really stepping up to the plate to educate the public. I think that we have relied on the expertise from the CDC, and we quote the CDC in terms of the guidelines that we follow. We have, when Edward said that the government is a mess, I agree, and we often find conflicting reports. One just came out and was highlighted in the New York Times about use of N95 respirators, where there's the ability to decontaminate them, perhaps, and CDC recommends that, and then FDA says no. So who do you listen to? And they're both the government experts. But I think that our members have really focused on treating the patients that come in our front door.
Thank you. Amira, we were talking about preparedness. What do you think are some of the most important changes to be made in the preparedness space? What lessons are we learning so far?
I think Ashley highlighted a really important point, and that's the fact that a lot of times, sorry, I don't know if you could hear the background, working from home with kids. I'm going to mute for a second, sorry.
That's quite all right. We'll switch gears here for just a moment. Ashley, you mentioned provider relief, and we have provider relief through the CARES Act and the Paycheck Protection Program and Healthcare Enhancement Act. These have been important pieces of legislation to bolster hospitals, and even for next time, to ensure they're willing to step up and face the challenges of any future pandemic. What, in your view, still needs to be done?
So I'll make this quick so that Amira can get back talking. Hospitals have received a lot of funding from the government, both in terms of the emergency fund, which is now funded at about $150 billion. About half of that has been, actually less than that, I'd say a third has been paid out. There's a little less than $100 billion in there. And it's been very helpful for hospitals. We also had increased payment for COVID cases. The government got rid of some cuts that were coming our way, got rid of sequestration for several months. But what we're hearing is that it is just a dime in the bucket, that it really doesn't offset enough. I think I just saw on a website earlier today that the emergency fund expected to cover 2% of hospitals' revenue during the time period, which is really, that's not enough. It's just, and the money went out in disproportionate ways, which is why there have been several waves of it. So the first one was just a general expenditure based on fee-for-service revenue, and I don't know how detailed your audience wants to get here, so I'll probably cut it shorter. But there have been multiple disbursements, and it just hasn't been enough.
Do you anticipate any course corrections in terms of the disbursement so far? There have been some news reports about the disbursement formulas, therefore driving funds towards hospitals that may have been in a better financial position than others.
Yeah.
You see?
Yeah, that's correct. So the first disbursement was really based on Medicare fee-for-service revenue, and it was just to get the money out the door as quickly as possible, and that was $30 billion. The second, sorry, that was $20 billion. The second tranche of $30 billion tried to true up hospitals in that it was based on net patient revenue. So that helped. So if you didn't have a high Medicare population, but rather served a high Medicaid population, we could capture that. So some people got a lot of money in the first tranche and none in the second tranche. But it didn't necessarily take care of hospitals that have high uncompensated care, and it didn't compensate for hospitals that are in hot spots. So they did do a hotspot distribution of about $12 billion to those hospitals that saw a disproportionate number. It was 100 or more COVID cases by April 10th. And then they also did a rural distribution because, as I mentioned earlier, rural hospitals have really seen a huge impact. And given that a third of them were losing money beforehand and they operate in such razor-thin margins, the lack of net patient revenue, they just don't have the reserves and the days cash on hand to stay open. So that was a fourth tranche, I would say, of $10 billion. There have been some other money out to the nursing homes, some to the Indian health reserves. I think that in the future, we are seeing a second hotspot distribution to take care of those that really saw their surge after that April 10th date. And I think that we will see some money, knocking on wood, for those safety net hospitals, the real super safety net ones that have high uninsured, very dependent on government payers, all of which pay less than the cost of caring for patients, to keep them afloat. That doesn't get at your topic of, why did Stanford get, Stanford, which has a big reserves, get money, and, your small community hospital down the street that doesn't, why didn't they get more money? And I think that some of this is just really complicated. It doesn't mean that Stanford lost less. It just means that it has more reserves. And it is interesting that there's additional funding going out for other programs like education, et cetera. And some universities, as we saw, got lots of funds and were asked to give those funds back. We had 90 days from receiving the funds to accept the funds, and it's unclear at this time how many have actually done so. So I think we'll learn more. I think actually today is the last day for folks to acknowledge the funds or return them from the first tranche. So we'll see what happens.
Terrific. Thank you. Amira, we want to turn back to you and talk a little bit about what you think are the most important policy priorities related to the public health infrastructure. And we have a question from our attendee also about data and the unreliable data and inconsistent reporting across the states. Is there hope for this situation improving?
Right. So the first piece about preparedness, again, we've known for a while that we were going to be in big trouble if there was going to be a large outbreak, and this has shown it. I think what I'm really concerned about is we are on a trajectory for more pandemics, quite frankly, and it is really worrisome that instead of building up systems, we've been, slowly dismantling them, sometimes not intentionally. It's just that when you, don't prioritize public health infrastructure, that's one of the consequences. And, Ashley had mentioned that oftentimes hospitals aren't reporting to health departments, or they're not communicating closely. And, this is a key issue that really feeds into the data issues that you just brought up in that question, because a really critical piece of any health system is the surveillance piece. And where are you going to get that information about cases, especially of important infectious diseases, than a healthcare provider or a hospital system? And we've known for a while that our infrastructure, the way our healthcare system is set up, all of the different electronic health record systems and other systems in place, they don't really allow for a rapid compilation of data. And that's a real problem in the US for surveillance. And so we're constantly, trying to do nationally representative surveys or assessments to get an idea of what the actual burden of certain diseases is, because we don't have a robust surveillance system in place. And, there's been There've been lots of initiatives put forth, and some years we do better with some health issues than others. And I think this is an area that we do have to prioritize. And this outbreak has really highlighted where we could do better. Regarding the question, there are lots of initiatives underway to ramp up infrastructure, including testing for COVID-19 and reporting systems. There are lots of discussions happening right now about how do we have better communication between the different health departments, how do we communicate across state lines. All of that is really important. And, the optimist in me is really hoping that we will come out of this with, if not stronger public health systems, at least a clearer understanding about what we need to do to improve our public health infrastructure.
Excellent. So, Ed, we're getting a number of questions about your survey. One is, our audience is eager to know if you will be having another wave, and if there is a way to dig into this rural-urban juxtaposition. Are the attitudes towards social distancing different? Is it because is that true regardless of the prevalence in the rural area, or is it sort of driven by the realities of the disease on the ground? And then I want to come back to you with the notion, your study makes the case that Americans were far more concerned about public health and the economy when you fielded it across the political spectrum. Do you think that has changed, and does your report in any way foreshadow today's events around the demonstrations voicing dissatisfaction with inequities in our country? That was a lot.
Wow, that is a lot. And the answer to the first question, do we foresee going back into the field and collecting follow-up data? The answer, yes, until yesterday, was no. We like to say that we temporarily retooled our knowledge factory to turn to the most pressing public health crisis of the day, which is the COVID epidemic. But it was enormously disruptive to our mission of addressing what I consider to be the world's greatest public health challenge, climate change. And so after it really was incredibly disruptive, we decided we were not going to go back to the field. But just yesterday, one of my former PhD students who now works in New Zealand, he told me something that got me to change my mind. He said the rate of infections and deaths in New Zealand is largely negligible. And he actually has some funding. So the reason he contacted me is he wanted to use our survey instrument to survey New Zealanders. And when I heard that, I guess I'd read about that, but it just didn't sink. And so I think we might be going back out to the field to do it again, because and doing it specifically in parallel with my colleague in New Zealand, so that we can look at how Americans' attitudes have changed and how those compare to Kiwis' attitudes, to see whether or not, some portion of that is attributable to just public acceptance of the measures that we need to take. At any rate, so that's what I know. The question about urban-rural differences is a really sophisticated question, and I don't have data because we haven't analyzed our data in that way. We could, maybe we will, but yes, there's clear, epidemiologically speaking, where there is less virus, where the epidemic is not really, fully blown, you have a certain amount of latitude to be, to enforce or to be less vigilant about protective actions. In New York City and Washington and Los Angeles, et cetera, we've still got to be incredibly vigilant because we're still dealing with a, full-on epidemic. So to what degree are the differences between urban and rural attitudes and behaviors attributable to identity politics, as I mentioned earlier, versus the reality of the epidemic? I can't say. All I know is it's a darn good question.
Excellent. Well, thank you to our audience.
Can I pivot to one last thing that didn't come up in the question, but is very much on my mind today, because the Washington Post released a survey this morning which shows that at least 30% of Americans are are showing what I would consider vaccine hesitancy, COVID-19 vaccine hesitancy. Of course, vaccines don't yet exist. They're all there. A number of them are in clinical trials. But from a, the way we end this pandemic is we develop a vaccine and we deploy it broadly. This is the way we get this in our past as opposed to in our present. And the fact that 30 and other surveys have shown that vaccine hesitancy is potentially as high as 50% of American adults would be hesitant to take the vaccine, that's really distressing. The Washington Post survey this morning showed 15% who were pretty much committed to the fact that they would not take it. I don't know that we have any idea, Amira would be the one to say, but at what level of immunity through vaccines or prior infections we would need to, at what level we would get to herd immunity, but knowing that 15% of Americans right now are saying, ain't no way I'm gonna have that vaccine, this is a cause for concern, and this is a cause for us to start thinking very clearly about how to, what it's gonna take to reassure the public that once a vaccine becomes available, this is in all of our best interests to cooperate with the program.
Excellent, thank you. And maybe this is where we can revisit